Good evening. You're very welcome to tonight's live stream on the Irish Inquiry. And I'm going to be looking at, I suppose, the effect of COVID. And my guest is a GP who is based in a rural practice. But before I begin, I would invite you to please go to the Irish Inquiry website, and there is a drop-down box there, Help Us, and you can enter details of how you can volunteer your technical skills, or if you want to donate a few euro, that will go towards the cost of, I suppose, maintaining the platform. So before I introduce you to tonight's guest, I just want to play a video clip. It was recorded in September at the COVID committee, and as you know, the COVID committee, the Dáil COVID committee, was chaired by Deputy Michael McNamara, and this is the response that he got from the participants that day on what they wanted to see happen.
Well, again, say thank you for the privilege of being able to talk to you. My view is that the most important thing, as Dr. Gisela alluded to, is social cohesion and political stability. I think many people have completely underestimated how divisive and this epidemic and pandemic can be, and we've seen it in some other countries. So my view is that what we can do with decision-making that is yet open, debated and transparent, but yet keeps us together as a people is really essential. If we fracture, then we won't succeed.
Thank you, Professor Ryan.
Thank you again for the inclusive discussion. I think we need more of this as a country. I think that we need to move from a reactive way of dealing with the virus to a long-term, realistic, proactive strategy. It needs a lot of public discussion and inclusiveness. I think a lot of the discussion that we've been having in this country has been about health versus the economy. That's how we're talking. What we really mean is we're discussing 2019 versus 2020. I think we need to accept that the world of 2019 is not coming back to us anytime soon. We need to face this. We need to put all of the different choices on the table and compare the outcomes of them side by side. What would each strategic option really be like for us to live with? And then what one do we want to choose as a society?
Thank you. Thank you very much. Professor Schaefer?
Yeah, again, I would like to thank the committee for giving me the opportunity to speak here. And as the other speakers, I think the most important thing is an open debate. And I think so far we just haven't had enough debate about the different approaches, an open debate about what data, what facts are out there, and how do we want to proceed from here. I think it would be a good starting point.
Thank you very much. And lastly, Dr. Gisela.
Two things. Watch out for undemocratic decisions that are using emergency legislation in a case when it may not be needed. That's number one. Number two is this will be with us for a long time. We will have to learn to live with this virus, unless a very good vaccine comes up before Easter, which I doubt.
Okay, so the overriding message that was coming from those people who appeared before the Dáil COVID committee is the need for dialogue. But sadly, in recent months, there has been just, I suppose, a dumbing down or a silencing of anybody who is going against the prevailing narrative. And indeed, a number of medics have been silenced. I suppose one of the more prominent ones was Dr. Vihili, who was forced to resign his position from the HSE. And tonight, my guest is a GP from a rural practice in Ireland, and he's going to chat to me about his experience for the last year. And he's going to explain now why he cannot appear before the camera. You will just see his silhouette. He cannot use his name, so I'm going to call him Tom for the purpose of tonight's interview. It's not his real name. So, Tom, I'd like to welcome you to Centre Grant.
You're very welcome.
can you explain to the people who are watching why it is that you are not going to appear before the camera tonight?
Well, I can explain why, because I can't explain why people send me hate mail, but and threats and different things like that. But that's what I receive fairly frequently. So I don't know why people feel the need to do that, because all I want to do is help, and I think I have followed all the research, followed everything, and have solutions to the problem. So I don't know why, but I can't, for the safety of my own family and all that, I don't feel comfortable appearing in public, which I think is a shame in a democracy, to be honest. But that's the way it is at the minute.
Yeah. Sadly, we have arrived at a stage where doctors are not comfortable speaking publicly, and those attacks that you have come under is because you actually ventured to share some of your views on social media, and as you said, the response was terrible hate mail, and it's widely published in today's newspapers how a consultant in Tallaght Hospital, Dr. O'Connor, shut down his Twitter account yesterday following an approach by a PR consultant who is reputed to be close to the health minister, and in that correspondence Dr. O'Connor was advised that speaking out on social media was compromising his position as a consultant. So it seems now that anybody that dares to speak out against the prevailing narrative, or not even to speak out against the prevailing narrative, to put forward an opinion that is not in line with the prevailing narrative, they are silenced. So Tom, you might just give us a little insight into your background, how long you're a doctor, and a little bit about your practice, please.
Well, I'm qualified nearly 40 years. It's just a long time, I suppose. I've been practicing really all that time. Practicing in a rural practice at the minute. I practice in inner cities in England. I originally trained as a pediatrician, but it was so repetitive that I just couldn't see myself doing it. So I shifted into general practice because it was more interesting, and it was more people focused as well, which was you weren't treating diseases, you're treating people, and so I find the whole life fascinating, and particularly the interaction with the patients. The most interesting part of medicine really is that the science is fantastic and wonderful and all that, but it's really just trying to help people, really. I think it doesn't matter what circumstance or whatever they're in. And in my later life, I got involved with classifying diseases. So there's an International Health Terminology Standards Organization, which is a big global thing. And I'm now an alumni of that, so I can classify illnesses for their coding system, which was a very laborious process to go through. But it's the whole idea of that is to try and keep the message in our clinical records accurate and transmissible from one person to another, where there's no error made in that. So again, in systems that use and health systems that use that system, there's a lot less mistakes made through ordinary everyday practice.
Okay. So we can see that you're a very diligent doctor, very concerned about your patients, and very concerned about keeping abreast of the latest developments in medicine. So yeah. If we can move on now, in March of 2020, lockdown was announced. So will you tell me a little bit about your experience in your practice for the last year?
Well, if we go back even further, right to January of 2020, when the Chinese announced that they had this outbreak of this SARS. And initially, it seemed that most people didn't really pay a lot of attention to it, even though it had the potential to be very dangerous. And it did concern me reading about it. But I followed a scientist from Stanford, Michael Levitt, and he was doing a lot of work on, if you remember, the cruise ship, the Diamond Princess, and it was isolated off the coast of Japan for 4 weeks, and he studied it as well as a lot of contacts he had in China. And his conclusion, even by March, was that this wasn't a particularly dangerous disease. That in many respects, that we had dodged a bullet. And like when any new virus comes along, it can be absolutely devastating and lethal. And we should never ever downplay that. But with this one, it didn't look that way. But of course, you still have to experience it. So I spent a lot of time triaging out of hours, talking to people who felt that they had the infection, etc., etc. But in the whole time that I did that, and in the whole time in my own practice, I never had to refer anyone to hospital. So what appeared to me was that the mild symptoms were the predominant people that were getting infected. Of course, we had the absolute tragedy of the elderly people being the most susceptible. I don't really kind of like this term end of life or whatever, that they were near the end of their life, but they are the ones that were disproportionately and overwhelmingly affected by this virus are people who are in their 80s and have exceeded what people call life expectancy. So it's merciful in many ways that, unlike previous pandemics, particularly the Spanish flu, which would be the utter gold standard, if you want, of pandemics, that the young, and in fact nearly everyone under 70 has practically been spared from the effect of this virus. So over the course of the year, I think I had to admit one person to hospital as a precaution. Now, I don't have many nursing home patients, so that may be a skewed experience on my part, but certainly COVID-19 was not a particular concern of mine. What increasingly became a concern of mine and remains a concern of mine today was the effects of the lockdown. It kind of didn't really manifest itself very much in the first 6 months. But I think this one, we did notice with grave concern, our elderly patients in particular, the ones that we were supposed to be protecting, they were simply fading away in front of us. People who would normally have come to see me, and they would have dressed themselves and they would have been shaved and, presented themselves, they suddenly started shuffling in their slippers, and they weren't washing themselves and all of this kind of stuff, which is very distressing to see that go on. And no matter how much we tried to motivate them, we just didn't seem able to do it, and then they just kind of disappeared off the radar altogether. They weren't contacting us in any way. So we instigated, with my secretary, a kind of call around. So we would put them on a rota and phone them as often as we could. And it was just tales of loneliness and despair amongst that group of people that we were supposed to be protecting, and not a group of people that should be discounted at all, ever. As far as I'm concerned, everyone is equal. It doesn't matter how old they are. So that it was a very emotional and very deeply disturbing experience. And then in the last part of the year, getting towards Christmas, it was an absolute tsunami of young people who were in great despair and distress. It presenting with what we would call adjustment disorders, which are things like anxiety and depression, but at a much deeper stage, at a much more acute or severe presentation as a first presentation. So I ended up using a lot more medication that I would normally ever use in people like this. Then I started to notice, well, throughout the year, I'd been noticing people who were presenting so late with disease. I mean, I had one guy in particular, I remember, who had a fracture for 6 weeks that he hadn't seen to, which had paralyzed his hand. And I don't think his hand will ever recover. And a similar one with someone who paralyzed or that injured their foot and paralyzed the nerves in their foot. And I don't think that will ever recover either. And just endless not being able to access services for people, particularly special needs children, speech therapy, cancer diagnosis, anything, you name it. I cannot seem to get any traction. So I'm trying to deal with all of these things myself in a very modern technological world by really very old methods. And I find it terrifying that I would normally diagnose about 30 cancers a year in early stages. And last year I only diagnosed one. So, you know, where's the other 29? I don't know.
And if I may ask you, Tom, is it that the people didn't present at your surgery, or that they did present at your surgery and you weren't able to get tests for them? Which was it?
Well, I actually caught this virus myself quite early on, but I kind of knew it would anyway. And even though I was wearing surgical masks and all the rest of it and doing all that, I still caught it, because when you're a frontline healthcare worker, you're at risk, and you know. But that's the gig, as far as I'm concerned, you know. So I was ill in March and April and recovered very well, and so I never closed my doors. So I was seeing every patient face to face that would come, but very few of them would come. That was part of the problem. So we looked at other ways that we could help, try to help in our own way. But my door has been open for the whole time. I haven't taken a day off since, to just to make sure that anybody who wants to come is concerned about anything they can come, you know. And I've seen a lot of other doctors' patients who were getting phone calls and stuff, and you know, I don't know why. I can't understand why that should be the case. I don't know why.
So are you trying to tell me that your surgery remained open and that you saw everybody that came to you?
Everybody who wanted to be seen, yeah.
Everybody that wanted to be seen.
Now, to be fair to everyone else, I mean, I had the infection and I was immune, so
right.
I was less fearful of it, but I was not fearful of it in the first place. But obviously, I haven't been through it. I was less fearful, and.
But to ask you the question, again, so are you telling me that there were people coming to see you in the surgery that were not your patients because they weren't able to get a face-to-face visit with their own doctor? Is that what you're trying to tell me?
Yes. Yes. Well, that's what they were telling me. So I have no. I don't know whether that's true or not, but I wouldn't refuse to see anyone who wanted to be seen. I mean, so that's just what they were telling me, and some of them were very sick, you know.
And what was your experience then throughout the year in getting people to hospital and getting appointments for people in hospital?
Oh, well, we just can't. I mean, it's the hospital are doing these virtual clinics, and then they're loading all the work back to us, but we don't really have the wherewithal or the manpower or whatever to do half the things that they're asking, and a lot of the communication is not very clear, so we don't know what they're doing, what they're requesting of us, and so the whole system just doesn't work anymore. And from what I can see, and it's all focused on one disease, which just does not make any sense at all, even from a public health perspective. You can't just focus on one disease, particularly a disease that does not but affect people very badly. The vast majority of people will never be injured or affected by this disease, and there are things we could do to even reduce that.
Okay, well, maybe I'll come back to that point and pick up on that point in a few minutes. And I suppose the whole basis for diagnosing this this disease, COVID-19, is the PCR test. So tell us a little bit about your understanding of PCR tests.
Well, okay. Well, PCR is, I would not regard PCR as a test. Okay, so PCR was never designed as a test. It's a laboratory process for investigating genes and genetics and very, very small particles in the body. So it's not a test as such. So the person who invented it was a guy called Carrie Mullis, and he died unfortunately last year, natural death. And Carrie said that it should never be used to diagnose an illness, and that it cannot tell whether or not the agent that you find is actually infecting you. So so that's one thing. But the problem with PCR, yes, you can use PCR if you have sequenced the virus that you're looking for. So if we imagine, for example, say we imagine a Lego block, you've got a whole pile of Lego with numbers on it, and you just build a big tower of Lego, and it's got a random sequence of numbers on it. Well, that's the virus you're looking for. So you can take a magic piece of Lego and put it down at the bottom of that, and it will copy it up. So you've now got two viruses that you're looking for, two copies. So you split that, and you just keep doing that, and you keep doing it and keep doing it. When you do that 30 times or so, you're up around the millions of copies. And when you do it 40 to 45 times, you're up around the tens of billions of copies. So, but the other problem, so that test, if you run it at cycles above 35, probably even 30 or less. So every time you repeat that process, you're just magnifying what you're looking for. That's one of the problems with it. So what you really want to do if you're trying to treat an infectious disease is to look at the dynamics of the disease. So in SARS.
Can I interrupt you there, because we actually have a video clip now from the Dáil COVID committee chaired by Deputy Michael McNamara, where I think in this instance it might be Dr. Cullity from the I'm not 100% certain on this, but certainly he asks the doctor present about the PCR cycles. So if you can roll it there, Stephen, please.
Could I just ask one brief follow-up on testing to Dr. Henry? PCR testing, there's been a lot of discussion in social media in particular on the number of cycles that are used, and some people claiming, doctors internationally, that because of the number of cycles used, that it can show up as positive persons who had the virus some time ago and are no longer symptomatic. Equally, I've spoken to Irish doctors who said that they're more concerned with false negatives than false positives. Dr. Henry, would you comment on that?
Yeah, good question. So first of all, on the false negative, it is the most sensitive test we have, but it is not absolute sensitivity. And the sensitivity relates and correlates closely with how symptomatic an individual is. So clearly, if somebody is actively shedding the virus and is quite sick, you're much more likely to get a positive test when that person actually has the virus. When somebody's asymptomatic, it has a lower sensitivity. And such is the nature of all tests, Deputy, that they're of a stronger sensitivity in symptomatic individuals and asymptomatic individuals. And the second question related to, Deputy, the second part of the question was?
Well, just the number of cycles of testing that you're likely to show people who've had the virus a very long time ago and are not symptomatic and maybe not even be shedding anymore. And there's also the issue of a margin of error that's part of all testing, I think.
Yes, the manufacturer defines the number of cycles that goes with the test. What I would say is that we do know, because the PCR test picks up on RNA of the virus, that it is possible to find residual RNA after infection has resolved and the person is no longer infectious. And we've seen that sometimes in some cases for many weeks after a person ceases to be sick and ceases to be infectious. So that's one of the quirks or problems with this test, is it can pick up on residual RNA weeks after active infection and after the person is no longer infectious.
And how many cycles are utilised in the Irish testing?
I can't answer that, but I'll come back to you, Deputy.
Thanks very much. Thank you, Dr. Henry. Thank you.
Okay, so there we saw Dr. Colin Henry appear before the Dáil COVID committee, and shortly after that, Dr. Cillian de Gascon, who is the head of the National Virology Laboratory in, I think it's based in UCD, he actually tweeted that they were using up to 45 cycles. So I suppose, really, without going into much more detail, Tom, it's very, very clear there from Dr. Colin Henry that the PCR test is not satisfactory, that it is actually diagnosing people as being positive, people that have long since recovered.
Well, that's also the worst of it. That's not even the worst of it. So PCR, as Deb just said, will pick up dead virus. So you can be positive for months. But if you actually look at what the CDC have said about PCR, if I can very briefly describe the dynamics of the disease, right? So you get infected, and for a period of maybe 2 to 5 days, maybe a little bit longer, in that 2 to 5 day window, you're infectious, so you can infect someone else. Then you stop producing the virus, and sorry, we're getting a bit of interference here. I don't know why that is. Give me a second, sorry.
Okay.
Sorry.
I suppose while Tom.
If we just get back on that, so you have only maybe even hours, like maybe 4 hours, just 5 days maximum to catch an infectious person. So what the CDC basically said, and what no matter how many cycles you run, so you're only going to find about 5% of people who are infectious at that with PCR. So what you're trying to do is, what we should be trying to do in a public health situation of a pandemic, is to catch people when they're infectious and get them to isolate. And that can be done with a test called a rapid antigen test, which is about $1. It costs about $1 or maybe $2. And we could have given out millions of these to homes or families all over the place. And you can test yourself. It's a test that you can do on yourself 2 or 3 times a week, whatever. If you wanted to visit your grandmother, whatever, you do this test, you get the result back in 5-10 minutes. It will tell you whether you're positive or negative. And it will be about 90, upwards of 90% plus, 95% plus sensitive in the infectious period, in the period where you want to catch the thing. And then you can self-isolate, so you don't need to contact trace. You can tell other people around you can test themselves. So this is called the lateral flow test. It is the ultimate solution to the problem that we have. PCR is too slow. It picks up cases too late. It has too many false negatives, and it has a massive number of false positives. And part of the reason it has a massive number of false positives is because of that magic Lego block that I told you about. It's called a primer, and the primer that was used in 70% of PCR tests in Europe was not even a sequence of the real virus. It was made up. And there was a particular virologist in Germany called Drosten. He made this up, published his own paper, peer-reviewed his own paper, published his own paper in 24 hours, within 24 hours. In science, that is unheard of. You would have to have a peer review by separate people over a period of months. He did this in 24 hours. He gave that sequence or that primer to the World Health Organization, and they used that all over the world. A very world-famous genomic scientist, Kavanagh, who worked on the Human Genome Process, said that this is even it's so inaccurate it can even be positive for water. That is what Kavanagh said.
Okay. It's just going to take me a little while to unpack what you've just said. It's quite astounding. So what you've actually said there is that there is actually a home kit available, a bit like a pregnancy test.
Absolutely, yeah. Exactly like that, yeah.
And it's very cheap. And people could be constantly testing themselves.
Yeah.
They would know immediately then when they had it, and they could immediately isolate.
Yes.
And that is not being done. So people are going then for PCR testing, and it's taking days. They're not self-isolating. There's huge.
Well, they're also. You're not
yes.
catching them in the infectious period, so you can't lower the transmissibility of the virus unless you get people to isolate at the right time. So that's the critical thing, and that's what the lateral flow or the rapid antigen test does. It does that brilliantly. Now, I will send you links to all of this so that your audience can read it and see it for themselves.
Yeah. Okay. There's two things now I want to say there. The first thing is that we had Deputy Danny Healy-Rae on Centre Ground a couple of months before Christmas, and we played a clip where he had asked the Taoiseach in the Dáil to confirm whether or not there was actually a member of ENFIT who was benefiting financially from PCR testing. Micheál Martin turned away from him, and he went on to speak about something else, and he completely stonewalled him. And we have a clip here now where Deputy McNamara in the Dáil asks, he was the then Taoiseach, Leo Varadkar, he asked him about the cost of PCR testing, and actually it's quite frightening. So if you can roll that there for us, Stephen.
We had the HSE in last week, and I asked what was the testing costing, and it was at the end of a very long day. We were confined to 2 hours, and I was told hundreds of millions of euros, and that was as specific as we got in the time period available to us. We can't bring in the same people every week, we've a lot to cover. But Taoiseach, I'm wondering, do you have any more information than that on the cost of testing per person, the COVID testing and what it's costing?
Yeah, thanks, Deputy. I might be out of date on this, but the last time I was briefed on this, which was a week or two ago, the estimate for the cost of testing for COVID this year will be somewhere between 400 and 450 million euros. And that is because of the fact that the average test, or the test costs about 200 euros a go, which is a lot of money. I might be out of date, but that's the most recent briefing I had.
My God.
I mean, it is staggering, the amount of money that's been spent on this PCR testing. And Dr. Bill Turmey was interviewed a couple of weeks ago by Caelan Harrington, and he actually spoke about a veterinary lab being repurposed in order to carry out this PCR testing. So there is literally millions and millions upon millions of euro being made on this.
Well, with that amount of money, you could have given every family in Ireland like over 100 or 200 of these lateral flow tests to let them test themselves. I mean. And then they would have been able to self-isolate. The other important thing to say is that when the SARS is a very dangerous disease in a subgroup of people, that mainly old people, but there are other people, and it's very, very important to treat those people as early as you can. So you need to treat them, you need to catch them in the infectious period. So this is the time when they're replicating the virus within inside themselves. So they're producing trillions, literally trillions of SARS viruses within themselves. We now know for a fact that a treatment protocol introduced by the frontline clinicians from America, the Frontline Critical Care Committee in America, that uses a combination of a drug called Ivermectin and vitamin D, vitamin C, zinc, and quercetin, and different things, but mainly the Ivermectin, completely stops the replication of almost completely stops, or really massively reduces the replication of the virus at the early stage. And that means that you do not progress then, or less and less people progress to the more dangerous second stages and the fatal third stage. So by using the combination of the lateral flow test and the Ivermectin protocol, you're going to save so many lives as well, which is a critical thing too. And this is not, you can also use Ivermectin and the lateral flow test to test your staff and make sure that they're not getting sick. So to me, this is a kind of an active approach to tackling a disease rather than constantly referring to a pandemic. Well, okay, we know it's a pandemic, but it's a pandemic of a disease that we can detect and treat early. I don't know why that's not being discussed. I don't know why.
Well, I suppose the follow-on then from that is that these cases that are arising from this PCR testing is actually being used as the basis to bring about lockdowns. And secondly, it's being used to record the number of people who are dying from COVID. And so we've established now, not just you is saying it, Dr. Colin Henry is saying it, that PCR tests are not 100% reliable, and they're not reliable. So we have another clip here now about how COVID deaths are being recorded. So if you can bring that up now, please, Stephen.
Dr. Cuddy, if somebody who is asymptomatic shows no symptoms whatsoever of COVID, and they have a heart attack and are brought to hospital and they're tested, and it is found that they have COVID and they die soon thereafter, but this is somebody who's demonstrated no symptoms whatsoever, are they recorded as a COVID death or not? If they have tested positive for COVID, but ultimately came to hospital because they've had a heart attack or a stroke or fallen off the roof of a building or something like that?
We adhere to the World Health Organization case definition in terms of the recording and reporting of deaths. So in the situation that you describe, where someone has a positive COVID test, then it is a death in a confirmed COVID case. But such a case would be subject to a coroner's report as well. And as part of the ongoing validation of the data in our surveillance system, we would take additional details in relation to such.
Okay, but a coroner's report, sorry, I'm trying to be very brief. Obviously, a coroner's report takes a very long time to make its way through the system. So for now, they are recorded as a COVID death, but it may be that they are taken off that list at a later date. Is that what you're saying?
That's it, exactly.
Thank you very much. Thank you.
So, yeah, I mean, that's very controversial. Again, if you're talking about, you know, deaths and attributing deaths, a cause of death, it's always a very difficult thing to do. But if you look at Ireland in 2020, the way you get around this problem of bias, if you want to put it that way, I mean, it's not bias in the sense that it's something you want to do, it's bias in something that you just do. You look at all-cause mortality. So you just look at the total number of people who die in any 1 year. And it's a fairly constant number, about 1% of the population of most Western countries die every year, and you get a winter burden of death every year, which is fairly constant as well. So if you look at all-cause mortality, no matter what it is, 2020 had a lower all-cause mortality in Ireland than 2018. So that in itself tells you that even if you label everyone with COVID, we had less deaths in 2020, age-adjusted, standardised as you properly should do, than we did in 2018.
That is absolutely extraordinary.
Yeah.
And yet this is being used as the basis for lockdown and this indefinite lockdown that we're going into, and you know, we just don't have time to go into that in any further detail. So I suppose I just want to wind it up with you, this part of the programme. Just so for people that are watching in tonight, and I know that there is a pandemic of worry, fear, concern, and all of those things that's driving up people's cortisol levels and breaking down their immune system. What advice have you for our viewers tonight?
Well, I mean, if you go by again places like Stanford, and particularly Stanford in America, which would be the really top research places, and Jay Bhattacharya, people like that, who are you know, disease mitigators. That's what their job is. I mean, they would say that even if you're 80 years old, your chances of dying from COVID is 99.5% chance of survival, even at 80 plus. So I would try and reassure, particularly the elderly people, that they can protect themselves as well. It's well known, it's been known for 15 or more years, and multiple tests and studies, that if they keep high vitamin D levels, that they will fight off respiratory infections. Obviously, the social distancing does work, And in certain circumstances, of crowded places and things like that, masks can reduce droplet infection and aerosol infection. So those things are fairly well established. But I don't think that elderly people need to be as afraid as they are. And I think that they should not be afraid. At the very least, they should not be afraid to come to their doctor with any other problems that they have. They should definitely be coming to their doctor.
And if they come to you and they have COVID, can you prescribe ivermectin for them?
No.
What?
I can't, no. Because it hasn't been repurposed or licensed in Ireland for that use.
My goodness. My goodness. And is it available in other jurisdictions?
They're using it all over the world now, particularly in third world countries. They're using it. It's available over the counter in a lot of third world countries. Ivermectin is a drug for parasitic infections like ringworm and things like that, and more complicated ones. So it's been used in the billions of doses since 1987. It's a very, very safe drug. You have to use it in a treatment of COVID in early stages and in middle stages. You have to use it in a higher dose than you would normally prescribe it, but it's still very, very safe at that high dose. So, as I said, I will send you the links to all this information for your viewers to look at themselves and do their own research and see what the frontline critical care doctors are saying about it in the United States. And there's over 40 peer-reviewed papers now on the use of ivermectin to treat COVID.
Okay, Tom. Thank you for that. I have to say that it has been a massive eye-opener for me. I thought that I knew everything. Well, I knew a lot about it, about COVID and all of that. But I've just learned so much from listening to you tonight, and you've explained it in such simple English that I can understand, and we'll be coming back to you in a minute. Before I go to Peter, I suppose what we've been listening there to Tom, when Tom was speaking about his experience in his practice this year, that there has been an enormous human cost attached to COVID, people not getting appointments and so on. And I just want to show you now some newspaper headlines from this week. And I would like to pay tribute to journalists, to many mainstream journalists who are actually getting the news out there and getting word out there and getting an alternative view out there. So I suppose the first slide just looks at the 200,000 first-time appointments that have been cancelled. I'm not too sure if that is coming up on your screen because I'm not actually seeing, I can't actually see what's on the screen at the moment. Stephen, if you could share your screen with me, then I would actually see what's on it. I am not, so it's just a little technical hitch at the minute. I'm not actually seeing what's going out, and I don't have a way of communicating with Stephen. I don't have an earpiece in. So I'll just run through it then. The newspaper headlines, what has come to light in the last couple of days. So 200,000, over 200,000 first-time appointments for hospital consultations and procedures have been cancelled, and these have been added to the existing waiting list, which brings it to the region of 800,000 people now on hospital waiting lists. There has been a massive surge in domestic violence. The centres that are treating drug addiction says there has been a massive increase in the number of people turning up seeking treatment and help. There has been a huge increase in the number of alcoholics that have relapsed and are now drinking. absolutely fantastic article in the Irish Independent this week from Suzanne Harrington, who spoke about her own personal journey this year, where she had been sober for 15 years and she relapsed into alcoholism, but thankfully she has managed to come out of it and to regain recovery. But that was a direct result of lockdown. There has been a massive increase in the number of people presenting to A&Es for mental health. All mental health services have been shut down, and the only ones that are available now is in A&E, and there's a huge surge there. And of course, children are locked out of school, and this is having a very detrimental effect on their education. It is affecting children from poor backgrounds, children from rural Ireland that don't have access to broadband, and of course it is having a ginormous effect on children with special needs. And then if we look at the economic cost, today there are just under 500,000 people claiming the PUP payment, pandemic unemployment payment, at a cost of €142 million per week. And Micheál Martin has said that the budget deficit this year will be in the region of 25 billion. And there will be close on €40 billion borrowings this year to add to our national debt, taking it to just under €250 billion. So there's a huge economic cost that's going to have to be paid in the years ahead, and it's going to lead to a massive recession. And then in the midst of all of this, we learned from the Oxfam report that was published this week that Ireland's billionaires added a further €3 billion to their wealth since the lockdown began. Now, I don't know if Stephen is still there. Dan O'Brien, when he appeared before the Dáil COVID committee, spoke about the economic cost of lockdown. So maybe we might be able to see that clip.
My hunch again is that we need to follow a risk-based approach, and people need to be advised by medics how risky this is for them, and correct me if I'm wrong, any of the medics here, but the risks for younger people dying of this thing are tiny. In this country, not a single child or baby has died. Nobody under 15 has died. 8 people, and I checked this with the CSO on Monday, 8 people under 65 years of age who have no health issues have died. The vast majority of the population is under 65 and has no health issues. I think we need to assess individually how great a risk we face from this thing and adapt our personal behaviour on the basis of that risk. And finally, let me say that if we look at history of the past 100 years, holistically, what had the biggest impact on human welfare? Was it the Spanish flu? Tens of millions died, or was it the Great Depression, which led to social, political upheaval and eventually war? I can say as an economist that we are on track for a Great Depression type event now. I have no idea how things will turn out, but we know what happened in the 20th century. Look at your history books. What event had a greater impact on human welfare, the Spanish flu, or 10 years later, the Great Depression?
Yes. I don't think we need to comment on what economist Dan O'Brien had to say when he appeared before the Dáil COVID committee. Waiting quietly and silently in the wings is Dr. Peter Dunn, as always. You're very welcome, Peter.
Thanks very much, Anna. And
Peter, if I can cut across you now before you begin, maybe you might just tell us what your PhD is in, so that viewers have an understanding that you have a competency now to speak about these matters, what you actually do.
No, absolutely. Thanks very much, Anna. My PhD, I suppose, could be broadly designated as in agricultural and food biochemistry. Its specific area of expertise is in muscle and meat biochemistry. But there's also some beef production, some ruminant nutrition, so broadly falls under the rubric of agricultural and food biochemistry. And if I can just maybe orient the discussion,
I really have not that much to add about the PCR to add to what Tom has said. But I mean, he covered all the bases there. But the nub of all of this is the PCR test, and that's a polymerase chain reaction, and he explained it very well. I actually, we did see a flash of some lecture slides that I use from an abridged slide deck that I use, a much shorter series of slides, because normally I do a 3-hour PCR lecture which has 102 slides in it, and it's quite detailed. If I can just come to the issue of the peer review, because this thing, I mean, you know, you look at this as a professional scientist. Now, when I say I'm a professional scientist, and I don't want this to be about me, but you know, in terms of my credentials, I mean, it is about 10 years since I've worked in a laboratory environment. Effectively, I'm one of those people who kind of got to 35 as a postdoc, and you know, not everybody kind of gets tenured professorship. I mean, the majority don't. You know, it's one of those things. But I had a reasonably long career in academia. In terms of peer review, I mean, that's what I do. I know the scene, so to speak. I mean, I've published, and I checked last night, aware that this could be an issue tonight. I've 19 peer-reviewed academic papers. 11 of those as first author, 1 book chapter, and then I think of 43 other publications of varying but lesser standard, which really don't contribute to career progression. So that can vary from conference abstracts, research reports, technical abstracts, and so on, 1-page summaries. So there's a variety of those.
Okay.
So I do lecture. I do lecture in PCR.
Peter, sorry now to cut across you. So basically, what I'm hearing is that you are more than qualified now to speak about PCR. As you say, it's part of a 3-hour lecture that you give to your students. So you have competency in this whole area. Yep. So is there something that you want to add to what Tom said about the PCR test?
Well, one thing that he said, I would direct people just to Google Kevin McKernan from MIT. And there's a very recent, it's about a 45 minute clip on YouTube, for as long as it's on YouTube, where he was interviewed by Dr. Naomi Wolf. Now that's a very good interview. And again, I don't think I can really add very much to what Tom has said. He also, Kevin McKernan, and in fact, along with, I think, 14 other authors, one of whom was Kevin P. Corbett, who incidentally appeared on the Healthy Debate on the Irish Inquiry channel here some time ago. And he was also a co-author on the critique of the Corman-Drosten paper. And one thing maybe I just want to focus on, because there were a lot of technical critiques and valid technical critiques that they used. I mean, everyone was talking about the CT value, and that was sort of one issue. The other issue was the primers. Nobody was talking about primers, but the primers were I think poorly designed. One thing that I noticed early on, if I could say this, in my innocence and in my naivety, in the 3rd week in January of last year, just before I was due to kind of to teach on the agricultural biotechnology course that I lecture on, I thought, this is great. This is PCR is at the center of this. This could be a good case study. It could be something to engage students and to show them this is very important. And I went looking for details of the test, and I think I searched for about 40 minutes, and I came up with some stuff, some sort of 2-3 pagers from the World Health Organization with the WHO masthead and so on, but no technical details, not the kind of technical details that you would need to actually teach this in some detail in the context of a 3-hour lecture. And I thought, okay, mental note to self, something's not stacking up here. This should be, if it's, as important in the context of an emergency as we're led to believe. This should be front and center. I didn't know at that time that it had been published in Eurosurveillance, and that's maybe an angle that I want to maybe pursue a little bit in terms of the peer review, because as Tom has said, it wasn't peer reviewed, and it wasn't peer reviewed. And one can actually see on the masthead, or on the just below the published paper, I think we did have a slide, and I don't think we're able to show it, but it was peer reviewed, and I'll put that in air quotes, within 24 hours. There is no way it was peer reviewed within 24 hours. If I, in any of the positions I held, had engaged in that, if I'd done that. Now, does it happen? I can only speculate. I imagine it does. There normally would be some sanction for doing that. You might be disciplined to the extent of losing your job. I mean, that's quite unbelievable. And the conflict of interest as well is that, and I think we do have a slide that Stephen might put up, that Christian Drosten from the Charité Clinic in Berlin, he's actually an associate editor. So effectively, he's on the editorial board of the journal Eurosurveillance. And, you know, I kind of quipped to some friends. I said, did he send the email to himself? In fact, and I may be wrong in saying this, I think at least the section editor in the journal was a co-author on the paper. Now, one thing I think we need to elaborate for the public is, in terms of the peer review process, especially if you're dealing with an area like virology, where, you know, there aren't really tens of thousands of scientists, I can imagine, who are specialists in the area. And one thing you notice about we call it the Drosten paper, even though his first author is a gentleman called Victor Corman. So it's actually Corman et al. 2020. And Christian Drosten is the last author, and generally by convention, the last author is the corresponding author. So the work was done in his lab, and there's about, I didn't count them, but there's at least 14 or 15 authors on that paper. So you're kind of going,
Peter,
it's almost, yeah.
Peter, now I have to confess, you're losing me. You're losing me. So basically what you are, I suppose you're presenting in great detail, is that this PCR test published by the World Health Organization was actually not peer reviewed, and that is a no-no in the world of science. And if you were to present your work in such a fashion, you'd be almost struck off, or, you know, you just don't do it in the world of science. So I know the time is ticking on. So is that what you're really saying? That,
I mean, that essentially, in a very long-winded way, is, I mean, it's a no-no. Yeah,
that's what you're saying.
Yeah, it's quite unbelievable, and I hadn't realised this until sort of mid 2020, that this thing was, hang on a second, 24 hours, you can't, it normally takes, it could take 3 months, it could take 6 months.
Okay, now, the next question that I want to ask you, Peter, and you are moving in the world, you're moving, you know, your world is science, and your colleagues are scientists, so that is your area of competency. Have you seen a lot of scientists come out and speak about this and condemn what is happening, or has there just been a silence on the issue?
I would say that for the most part, it depends where one looks. So if you look on Twitter, for example, there seems to be, if I could say, you know, an increasing awareness of some of the, let's say, what wouldn't be regarded as best practice, or shall I say malpractice or malfeasance on Twitter. I think in the, you know, outside of the, could I say, the social media echo chamber, you know, I think a lot of academics are quite busy. So I would venture to suggest that in mainstream academia, you know, perhaps for quite innocent reasons, a lot of academics are quite busy and they haven't really engaged with the subject area. I think it's also fair to say, however, that if you stick your head above the parapet, that certainly people who may have realized that all is not what it should be, for fear of career progression, may be afraid to speak. And if I could just say that, science is also a very human endeavor. And, if you look at some of the other organizations and NGOs and so on that are, peripherally involved in this or have an interest in this, you start to realize that, a lot of scientists are driven by ego, by careerism, by their legacy, or purely just by funding considerations, which can mean that you have to adhere to a standard narrative, or which can be political in some cases. So all of these things have to be borne in mind as well. So peer review is the gold standard, but on this occasion, under the cover, if you will, or in terms of the plausible excuse of an emergency and a pandemic, they've gone in under the radar, and they've used this test to effectively blow up the world.
Okay, and I mean this test then. So we've just learned so much tonight about it, and so what you've given us now is a very, very good perspective in that. It's a bit like the Imperial College, I can't remember, his name escapes me now, that he predicted that there was going to be millions of deaths, and it was then that kind of propelled governments to go into lockdown because of the London Imperial College.
Neil Ferguson.
Yes, Neil Ferguson, that's the chap, and he eventually then was caught breaking the COVID regulations, and he was forced to resign. So I'm very conscious of the fact now that this has been a long discussion, and I'd like maybe to see a little bit of dialogue now, Peter, between yourself and Tom, if there's any, what shall I say, toing and froing that you want to do just for the next couple of minutes before we wind up.
Oh, absolutely. Thanks very much, Anna. And again, thanks to Tom for a fantastic contribution, and also for his bravery. I don't know if any of our audience have seen, it is publicly available. It was on, I think, Twitter and Facebook. It was in the social media sphere today. The communication that was sent from the PR consultant to Dr. O'Connor. And if you read the text of that, it's quite chilling. It's quite chilling. And have we arrived at a situation in society where, some PR consultant is effectively like a communist commissar? Is that the point we're at? Frankly, it's disgusting. It's unacceptable, and it's unacceptable that a general practitioner should receive hate mail. I mean, what kind of dregs would actually engage in that kind of activity? But of course, power will use whatever influence it can. It doesn't mind scraping the barrel to find the low-level psychopaths who threaten people, and the lesser psychopaths who are just involved in careerist progression or just stroking their ego. I mean, it's quite disgusting. So, I mean, in fairness to Tom, it's very brave. What he's done. One thing I was just curious to ask him. I mean, I just said this, and I have to really say, look, I'm not an MD, and I've the work I've been involved in, it's probably closer to veterinary medicine, and I don't know, but I would have a view, and I've said this to people, that the PCR test is wholly inappropriate, and really there should be protocols in place where the only time a PCR is deployed, and I know Tom will have a view on this, would be where patients present either at a GP or at hospital with a specific suite of respiratory symptoms. They're then tested for PCR test for SARS-CoV-2, and also PCR tests for influenza A and influenza B at least. And also then, if you want to bring it to its full conclusion, what should actually be done is then the amplicons, what we call the amplicons, those little pieces of the virus, should then be sequenced to take a sort of a belt and braces approach. Because just if I can say this for our audience, there's just to try and maybe make it simple, we're not with the PCR, we're not detecting a virus. We're not even detecting a part of the virus. We're only detecting a part of the virus. So we're only detecting about 1/100th of the size of the part of the virus that we call the RNA. So anybody who says we're detecting a virus, we're not. Hence, we can't tell the difference between, just degraded or dead virus material and live infectious virus. So I just wonder what Tom feels on that.
Well, that's absolutely correct, and that's the difference between using the rapid antigen or the lateral flow test, is that it will only detect the virus, the complete virus. So with the PCR test as well, I think you would agree, Tom, that you can, when you're talking about gene sequences or genomic sequences, well, the human body is made up of a lot of viral sequences. So one of the criticisms of the Gorman-Drosten paper was that it could pick up and amplify ordinary human tissue that just happened to have the same sequence as the virus, because it's so inaccurate, really.
Yeah, I've read that as well, Tom. Yeah, that there was one of, again, there was a bit of a conspiratorial bent to that, and part of the problem with this is because the entire process lacks transparency and probity, which goes right back to the Drosten peer review process. I mean, this thing is just it's. I really don't know what to say, but the entire thing is just one witch's brew of obfuscation, malfeasance, smoke and mirrors, and for example, I mean, one thing that also struck me back in January: if you want to design primers to detect a particular nucleotide sequence, now the nucleotides are the little, if you like, they're the basic building blocks of what we call the RNA section in the virus. If you want to design the primer, and the primer, there's about 30,000, there's actually 29,993, I think, nucleotides in the sequence of SARS-CoV-2. And the primers are actually about 300 in length, so it's about 1/100th of the length. Now that's okay, because if it was specific enough, that would be okay. But essentially, the issue is that you're not even picking up. You can't tell whether or not it's live or dead virus. It's completely inappropriate and much too powerful.
And also, it shouldn't. PCR was never designed to be done on an industrial scale. I mean, it's a very sensitive laboratory process. It's very laborious and has to be, completely sterile conditions, and everything has to be controlled and everything. And otherwise, you can't rely on the results. And particularly if you're doing research, that's critical. So
absolutely, there was one question actually. There was one major question, Anna. We do need to cover. We do need to cover one major question if we have about 30 seconds, Anna. In terms of how we get out of the shambles that we're in. We really need to get information on the testing contracts and the interagency testing contracts between the HSE and other state agencies, and especially between the HSE and private sector laboratory contractors, because that is obviously going to determine incentive structures and the motivations. And even at this late stage, that's going to have a profound effect on the case demic. So we really need to see, what terms and conditions are in those contracts, because that's going to determine largely how or if this can be unwound.
Okay. I just want to thank both of you. We have gone way over time. But I didn't call time on our discussion because this is, I suppose, a very, very, very unique interview. It's something that will not be seen on mainstream media. It wouldn't surprise me if there is an attempt to actually shut down this video when it becomes available and kind of maybe say that there's something wrong with it, because it has railed so much against the mainstream narrative, and it has raised so many important questions that mainstream media have failed to raise. So I just want to thank both of you. Before we go, I just want to give you both a final word. So Tom is I wonder, did Stephen mute the Tom's microphone? Sometimes he does that. Yes, I think Tom's microphone may be muted, and perhaps yours too, Peter. So I want to thank Tom, and I want to thank Peter most sincerely for tonight's discussion. I think that there is a huge amount to unpack in the days ahead. I certainly will be looking back over tonight's programme to grasp just fully what has been said. Before we go, I just want to announce that starting next Monday, and for each morning at 9 o'clock for the month of February, there is going to be a new 45-minute live going out every morning at 9 o'clock. Now, Stephen is going to kill me for this. It's to do with breathing. So I think Stephen may have a video clip that he wants to show as a promo for the programme. I don't know if that clip is going out.
Go on ahead, Anna. Go on ahead, Anna.
Stephen, has the video clip gone out?
Yes, it has, yeah.
Okay. Just a little technical issue. This is what happens when we're going live. So, Stephen, would you like to tell me what is the name of the programme?
The name of the programme, Anna, is called Breathing for Life.
Breathing for Life. So I'm actually going to sign up. If you go to the Irish Inquiry website, and indeed I'm sure if you go to the Irish Inquiry Facebook page, you will get details of how to sign up for this series, and it's free, so it won't cost you anything, and I'm definitely going to sign up for it. I've been chatting to Stephen today about it, and it's definitely something that I want to do, because it's all about helping to improve your breathing and improving the whole quality of your life, and there will be different experts on every morning. So that's Breathing for Life, beginning next Monday morning, and each weekday morning at 9 o'clock, 45 minutes, Breathing for Life. I want to thank you most sincerely for joining us tonight on the live stream, and I would ask you please to share the video as much as you can. I would also ask you to maybe have another look at it, and I suppose it will be a good source of material for discussing with your family and with your work colleagues and so on, because I think we need to raise the issues with each other that has been raised tonight by Tom and by Peter. Thank you so much for watching. Have a wonderful week. Banach Day or Galéir.